Yes, sir, we are live now.
So, good evening, one and all. I welcome all of you to this month's Innovation in Hematology webinar series, where we have monthly webinars covering clinically relevant hematology topics. And we try to look at pertinent clinical questions and try and discuss them with an international expert. Through this webinar, over the last 1 year, we have been trying to address challenging clinical scenarios where making treatment decisions and managing patients becomes a challenge which all of us face on a day-to-day basis. So for today's webinar is on management of TP53 mutated myeloid malignancies. This is one of those areas where we all feel that there is a lot more that needs to be done. Despite tremendous progress in management of acute myeloid leukemia and numerous new treatment options coming in over the past 1 decade, TP53 mutated myeloid malignancies, especially MDS and AML, still remains to be an unmet need in 2025. Very often, we are faced with the dilemma of whether to treat these patients with intensive treatments, whether to treat with HMA when to transplant them, and what should be the best way to monitor these patients post-transplant, if at all they are able to make it to a transplant. So today I'm glad to welcome Dr. Talha Badar, who's an assistant professor at the Department of Hematology and Oncology, Mayo Clinic, USA. Dr. Badar has done extensive work in the field of TP53 mutated myeloid malignancies, and we are all familiar with his numerous publications in the field. Dr. Badar also takes a lot of interest in teaching, and numerous tutorials and educational posts on LinkedIn and Twitter are familiar to all of us. He is a leading expert in the field of hematological malignancies with a particular focus on myeloid neoplasms. His clinical research interest includes the development of novel therapeutic strategies for patients with AML and MDS. He has numerous publications in international journals of repute, and his work has been presented at various national and international forums. Dr. Badar is a recipient of numerous accolades, including Outstanding Fellow Research Award at the Wisconsin Association of Hematology and Oncology meeting in 2019, Best Resident Research Award presented at HCA West Florida GME Consortium Annual Research, and People's Choice Award for the Best Research at Health Corporation of America West Division in 2017, among many others. So, without taking up too much of time, I would like to hand over the session to Dr. Badar. Before we stop sharing the screen, this is our team of doctors at Fortis Institute of Blood Disorders, where we have a team of 5 adult, 5 pediatric hemato-oncologists, along with uh, ID physician, critical care hematologists, molecular hematologists, among many others. So I'll stop sharing my screen and I'll hand over the session to Dr. Badar.
Thank you so much, Dr. Kumar, for such a nice introduction and for the invitation. Very happy to be with you guys and learning about your practice and sharing my experience and some of the work we have done and other colleagues of us here in how to manage deep mutated myeloid neoplasm, which has been a challenge over the decades and unfortunately not with much success. And the only option that tends to potentially improve outcome this group of patients is bone marrow transplant, which is the most well-established cellular therapies, if you may say, for this particular disease. So we'll start with the presentation. Uh, can you guys see this slide presentation, right?
Yes, your slide is visible.
Yeah. So we'll start with the overview of our today's discussion. We'll briefly shed light on P53 and oncogenesis and then we'll discuss briefly how the allelic burden of P3 mutation impacts outcome across the various myeloid neoplasms. We'll also discuss the T3 mutation in context of myeloid blast percentage. This the blast percentage really matters, or more weightage should be put on genomic data rather than merely a morphological finding of disease when it comes to P3 mutation. We'll discuss the immune phenotype of this disease and how relevant this is in terms of predicting outcome and also in terms of therapeutic modalities. We'll go over the historical data on conventional chemotherapies and outcome comparing intensive versus non-intensive approaches to manage this disease. Most recently, as you all know, venetoclax therapy has been a paradigm shift when it comes to management of acute myeloid leukemia, especially elderly AML, where this P3 mutation is more common due to ancient history of MDS and prior therapies for other cancers. Role of allogeneic stem cell transplant, it has been a controversial subject. Still, many believe with this disease, P3 mutated myeloid neoplasm, transplant is a futile process, but most recent data do suggest that the only thing that can improve outcome in a small subset of patients is bone marrow transplant. And then we'll go over the future directions, how we can improve our strategy in managing this disease with the available tools we have in our clinical practice. So, P3 is a guardian of human genome, and it has various functions, not only in cell cycle control and DNA repair, but also in terms of genomic stability, also in terms of apoptosis, metabolism, also has role in adaptive immunity. And there's various factors which can lead to alteration in this mutation and that lead to various cancer. This mutation is the most common mutation across solid as well as neurological malignancies, and it's also prevalent in myeloid neoplasm. So in general, 5 to 10% of individuals with AML will have this mutation, but it's more enriched among elderly patient population, as I mentioned earlier, those who had ancient history of MDS, or those individuals who had history of various cancer treated with uh, newer therapies or immune conjugates or radioisotopes that also link to therapeutic disease, and more enriched in that subset of patients. In generally, it's with the poor outcomes, and the outcome can vary in early phase myeloneoplasm, such as chronic disease, but advanced disease, the significance of allelic burden is less prevalent when it comes to this because there is various players who play a role in determining outcome, not merely the allelic burden when the disease is advanced, such as for those with high risk MDS and acute myeloid leukemia. So we'll discuss allelic burden and impact on outcome of P3 mutated myeloid neoplasm. The first paper, which has presented in detail the genetic profile and compared the outcome of P3 mutated MDS compared to those with wild type, was by Bernard et al. From NIH, and then they did genomic profiling of large cohort of MDS patients, and they found out those with single hit disease, those with single mutation without concurrent complex cytogenetics or 17p deletion or loss of heterozygosity. Those patients, single hit P3 mutation tends to have a comparable outcome with wild type P3 MDS, and those with multi-hit disease, multiple mutations with VAV more than 10% or more, VAV 50% or more, or VAV 10% or more with complex cytogenetic, all loss of heterozygosity tends to have an inferior outcome. So allelic burden did show to play an impact on this disease when it comes to MDS. However, in advanced MDS or AML, it doesn't hold true. We conducted this multi-center study, retrospectively chart reviewing and collecting data and looking at the outcome of single hit versus multi-hit T3 mutation in acute myeloid leukemia. As you can see on the top half of this presentation, you can see the genomic profile is distinctly different between the two groups, single hit versus multi-hit. You can see single hit, you have more clusters of somatic concurrent mutations compared to multi-hit where you don't see those. Multi-hit more commonly associated with complex cytokines compared to single hit. But when it comes to survival, as you can see, in terms of event-free survival, duration response, it's not merely different between multi-hit and single-hit disease. As I told you, when disease advance from low-risk MDS to low-risk MPN to MPN blast phase or high-risk MDS or secondary AML, that doesn't hold true because there are several other alterations or acquisition of resistant mutations that dictates outcome along with P3 mutation. Uh, and so similar observation have been made in MPN, in chronic phase MPN. We did this analysis in collaboration with various academic teaching hospitals across US. As you can see here, from the time of detection of pre-mutation and outcome in various subgroup of MPN patients, including those with accelerated blast phase. In earlier phase disease, chronic phase disease such as PV and ET, the outcomes are better compared to those with late stage disease or advanced stage disease, those with accelerated phase or blast phase MPN, even after censoring them at the time of transplant. When it comes to allelic burden in chronic phase MPN, such as those with PV and ET mainly, single hit disease tends to have a better outcome, as you can see here, compared to those with multi-hit disease. But when the disease advance to more accelerated phase or blast phase MPN, there's not much difference in predicting outcome. So it's consisting story that in high risk MDS, AML, or accelerated phase MPN, the allelic burden doesn't really seems to have an impact on outcome compared to those in early phase disease or chronic phase myeloid neoplasms. So we have learned over the years during our training in heme-onc that the blast percentage does have an impact on outcome. Initial studies include the like MDS studies or high risk MDS studies include patients which are oligoblastic up to 30% blast percentage and differentiate between into less than 30, more than 30% of myeloid blast. And that has, with conventional therapies, did show a differential impact on outcome. But when it comes to P3 mutation, it's a distinct entity. And ICC, new ICC classification has shown that P3 mutated myeloid neoplasm should be treated as a distinct entity. They did divide them into various blast percentage, less than 10, 10 into 19, and more than 20. However, in clinical practice, we see overall this biology or this disease tends to have a inferior outcome. As you can see here, this paper from a European group in which they've shown that MDS excess blast with blast percentage 10 to 19%, or higher blast percentage AML with 20% or more, it's hardly any difference in outcome among patients with P53 mutated AML. So in P53 mutated AML, the blast percentage doesn't holds value. It's the genomic alteration that predicts outcome for this group of patients. And as I mentioned earlier, the allelic burden outcome, this study also showed that in advanced disease, the allelic burden really doesn't have a differential impact if you have a low allelic burden versus high allelic burden. That holds true among patients with chronic phase myeloid neoplasms. So now the immune phenotype. We have learned that TFC mutated myeloid neoplasm tends to have a more immune enhanced cell filtration or immune rich phenotype. We conducted a study at Mayo Clinic utilizing CyTOF, which is a mass cell flow cytometry, and we used this technique to assess the immune profile of AML patients who are receiving venetoclax plus hypomethylating agent based therapy. And we did renograph clustering at the diagnostic marrow and look at the immune profile and relate with the outcome with this disease. We found two distinct population based on immune profile utilizing CyTOF, those who had an immune depleted phenotype and those with have immune rich phenotype. Immune depleted phenotype showed that these patients respond well with venetoclax plus HMA-based combination. There's some earlier preclinical data that suggests that venetoclax in combination with hypomethylating agent upregulates the immune surveillance or cytotoxic T cells to counter the leukogenesis or oncogenesis. Similarly, individuals with PIR3 mutated AML tends to have a more enhanced immune-rich phenotype with higher expression of CD8 and activated B cells, right? So, and all of these patients with PIR3 mutated AML who had immune-rich phenotype had a multi-hit disease with multiple PIR3 mutation or VAF more than 50% or VAF more than 10%, loss of heterozygosity or complex cytogenetics. Similar observation have been made with other colleagues or other groups. There was a study, a phase 1b study of flutizumab. Flutizumab is a DART, dual affinity targeting bispecific antibody, which engages CD3, which engages CD123 expressing myeloid cells and engages the T cells to cause cytotoxicity. So in this study, what they observed with this DART immune-based therapy, those with PIR3 mutated AML, they tends to have a more immune enhanced phenotype, and they tends to respond better with this disease. It's a single arm disease, a small subset of patient. However, when we further evaluate the immune-based therapy for this particular disease, it really didn't pan out. As you can see from in the future slides, where I will be briefly discussing about data on magrolimab. So, so we'll go back to conventional versus novel therapies for managing TFC mutated myeloid neoplasm. As you can see here on this figure, there are several therapies which have been evaluated for this particular disease, including conventional therapies, hypomethylating agent, liposomal, uh, daunorubicin, and cytarabine combinations, checkpoint inhibitors, CTLA4 inhibitors, as well as anti-CD47 monoclonal antibodies. However, we continue to struggle in improving the outcome for this group of patients. So this table showing various prospective studies looking at the outcome of wild type versus mutated P3 high risk MDS and AML, starting from hypomethylating agents such as azacitidine. As you can recall from AZA001 study, where they look at the outcome of P3 mutated high risk MDS and AML with HMA-based therapy compared to conventional chemotherapies, HMA-based therapy tends to do better because these patients have a chemo-resistant phenotype. They have impaired apoptosis mechanism that is required for conventional chemotherapy-induced cytotoxicity. So before the venetoclax era, HMA used to be a go-to regimen when it comes to high adverse risk profiles, such as those with complex monosomal karyotype or those with P3 mutation. Similarly, several other studies, including APR 256, which uh, tends to recover the TIP3 mutation. Earlier studies in combination with azacitidine showed response, but later on the phase 3 trial didn't show benefit in improving outcome with this combination. Similarly, checkpoint inhibitors have been evaluated for intensive chemotherapy or hypomethylating agent, and most recently magrolimab. All have been tried initial early results, but later on, when it comes to randomized studies and looking for outcome of disease with compared to standard of care therapies, unfortunately, we didn't see much success due to toxicity or not achieving the primary endpoint. So, going back to immune therapy based approaches, we shared earlier that PC mutated AML or myeloid neoplasm tends to have a more immune rich phenotype. And there are some initial phase studies that showed these patients respond better to immune based therapy. However, the Enhance 2 study was conducted in a randomized fashion in which azacitidine was combined with magro, which is anti-CD47. It works on overcoming the don't eat me signal, which is more prevalent in PC mutated myeloneoplasm and myeloneoplasm in general. In this study, the primary endpoint was complete remission rates and overall survival. These patients, overall, it's meant for untreated intermediate or very high risk MDS, but PC mutated myeloneoplasm were more prevalent. We haven't seen much success in terms of difference in response rate or overall survival, which was unfortunate. Similarly, the Enhance 3 study compared to Enhance 2 study was Magro with EZA compared to EZA alone. This study utilized triplet, Magro, EZA, and azacitidine and venetoclax compared to placebo, venetoclax, and azacitidine. In this study, The primary endpoint was different compared to Enhanced 2 study, in which this study primary endpoint was overall survival and secondary endpoint were response rate and duration of response. Initial results, which were presented earlier, showed that the response rate were higher, specifically among group of patients with previously mutated AML. However, later, as you can see here, more toxicity and adverse events were seen in the intervention arm compared to the standard of care arm, which leads to inferior overall survival. More commonly, the hemolytic anemia was a concern with this combination. As you know, the anti-CD47 monoclonal antibody can cause hemolysis. There are newer molecules targeting CD47 fusion protein in a way that minimizes the incidence of hemolysis, but that currently conducting trial are excluding patients with pre mutation. So unfortunately, another bummer, and we couldn't find a newer or novel agent to improve outcome for this group of high risk patients. We conducted real world analysis in which we looked at the outcome of PC-mediated myeloid neoplasm AML specifically, with evolving frontline therapies moving from 3 plus 7 chemotherapy to liposomal combination of daunorubicin and cytarabine to more venetoclax-based therapy in the most recent time. As you can see here from the bar chart, over 4 successive time periods, there's increased utilization of ven-based therapy, which is in green. However, when it comes to outcome, the event-free survival or overall survival, you can't really differentiate between intensive, non-intensive chemotherapy. Intensive chemotherapy includes high-dose cytarabine-based regimen, 3 plus 7 combination, a liposomal combination of daunorubicin and cytarabine, HMA or HMA plus venetoclax. So the median survival still ranges between 6 to 9 months for this high-risk group of patients. In multivariate analysis, the only factor that is shown to improve outcome is small subset of patients with allogeneic stem cell transplant. So, so now I will discuss briefly the response to ven-based therapy. As I've been told, as I was telling you earlier, the ven-based venetoclax has been a paradigm shift across the board in how we manage high-risk myeloid neoplasm. There is established data in acute myeloid leukemia. There is also initial promising data in high-risk MDS, and we're currently anticipating results of a phase 3 trial in which HMA were azacitidine is compared to azacitidine plus venetoclax in high-risk MDS patients. So we conducted this study in looking at the molecular signature and outcome of patients who were treated with venetoclax-based regimen. Earlier study analysis from Viale group showed that T3 mutated myeloid neoplasm tends to have a very inferior outcome with ven-based therapy compared to those with FLT3 and RAS wild type and those with FLT3 mutated. So similarly, utilizing data for more than 300 patients, we developed a molecular score in which favorable outcome was seen with ven-based therapy among patients those with NPM1, IDH2, and DDX4 mutated, and significantly inferior outcome among those with TC mutated or FLT3 ITD or RUX mutated. It compared and validates the observation from the Viale group, where PC mutated AML tends to have a inferior outcome with ven-based therapy. Then we look at the outcome to see that in elderly AML patients who are not eligible for intensive chemotherapy, does the addition of venetoclax to hypomethylating agent HMA, either decitabine or Vidasa, really improve their outcome? As what you can see here, in terms of duration response with ven-based therapy, we did see that the HMA ven-based therapy did show a high CR rate and duration response, but however, it wasn't statistically significant. When it comes to event-free survival, overall survival, we haven't seen much difference in outcome when we compared from HMA to HMA plus venetoclax. However, this is a retrospective analysis. There is selection bias and may not be able to clearly define that. But in anecdotally, what we have seen in high risk elderly AML patients, including those with PC mutation, when based therapy doesn't really improve the outcome as such. Having said that, if you have a younger individual with PC mutated AML who is eligible for bone marrow transplant, ven-based therapy does achieve a quicker remission rate. If these patients can go to transplant, you can improve the long-term outcome of subset of patients. So if you have a younger individual with pre mutation whom you think that have an available donor or is eligible for bone marrow transplant, vein-based therapy is still a valid option. But if you're treating a 70, 80-year-old with comorbidities, frail, declining performance status, where you feel that these patients may not be able to go to transplant, and our goal is to improve quality of life and prolong life in a manner that doesn't lead to more toxicity, then in those situations, hypomethylating agent is the best strategy, and we should avoid vein-based therapy, which can lead to more cytopenias and infection risk. So similar observation was seen in high-risk MDS. Earlier slide, I showed the outcome comparing HMA versus HMA-VEN in AML patient. This slide, we also showed in high-risk MDS patient with those with 10 to 19% blast, addition of venetoclax overall didn't improve the survival, but we did see improvement in response rate. Interestingly, intuitively, we feel the non-relapse mortality at day 60 and day 90 will be higher among individuals who receive HMA-VEN compared to those who receive HMA alone. But in contrary, we didn't see increased toxicity with better supportive care, more utilization of neutropenic prophylaxis with prominent and potent antifungal agents with strong activity against invasive aspergillosis. We able to manage the infection risk with supportive care. We be able to overcome the myelosuppressive effect of these combination, but it doesn't translate into proving survival. Having said that, these patients are older and most of them were not eligible to receive bone marrow transplant. Now, after discussing the three tumor biology with the allelic burden, relation of blast percentage, and predicting outcome, and going over data with immunotherapy, conventional therapies, and vein-based therapy, the only thing we have learned through this journey how to improve outcome for this group of patients with is by bone marrow transplant. LO, as you know, is a go-to therapy for 30 to 40% of patients with AML who present with adverse risk disease or who have residual disease after induction therapy, and has to be only hopeful option for cure. When it comes to PIV3, earlier data was conflicting. I would say prior to vein-based therapy or prior to better supportive care and how we manage our transplant patient, transplant wasn't the go-to thing for this group of patients due to high mortality and high relapse rate. But recently, if you see several papers from several group retrospective in nature, it's hard to conduct prospective study, transplant study for this subgroup of patients to various reasons. But various retrospective series over the last 4 years, I haven't seen any study that suggests that transplant didn't prove outcome for this group of patients. So in as I showed in earlier from our database, the only factor that is chose to improve outcome was transplant. In this analysis, we specifically look at the only transplant outcome to limit the bias, and only saw that how many patients were transplanted from our group of patients and look at their outcome. Only a small proportion of patients were able to go to transplant, as you can see here, after initial therapy or after salvage therapy in among patients who were refractory to initial induction. We did see that it improved outcome even after salvage therapy. As you can see here, the event-free survival, if you can see the 3 years event-free survival is close to 40 to 50% after induction, as well as around 30% after salvage therapy, which is significantly better if you remember from the earlier slide where I showed the median survival for this group of patients is 6 to 9 months. If you're improving it by threefold by transplant, even in a subset of patients, that is a success story. Is similar to overall survival. And what we saw in multivariate analysis, the factor that predicted better outcome is those who had a chronic graft-versus-host disease. As you know, that graft-versus leukemia effect is one of the factors overcoming the immune surveillance in among patients with myeloid diseases. We saw that those who had a chronic graft-versus-host disease tend to have a better outcome. Similarly, who maintained remission at day 100 post-transplant. We did an extra subgroup analysis looking at the outcome among patients who had complex cytogenetics versus those who doesn't with previously mutated myeloneoplasm. And as you can well imagine, those with complex cytogenetic tends to have inferior outcome, inferior overall survival compared to those who had a non-complex karyotypic analysis. So, looking at the predictors of outcome with transplant, although it's a study, a small subgroup of patients, only 60 patients out of more than 388 patients were able to receive transplant. The outcome were inferior among those who didn't had GVHD or who didn't maintain CR at day 100 post-transplant. Similarly, the conditioning intensity or post allo maintenance didn't had any impact in improving outcome. Maintenance therapy among transplant patients is a controversial subject. Several studies, if you see across the board in AML, if you talk about FLT3 inhibitors, if you talk about IDH1 inhibitors, HMA therapy, apart from few, none of the studies have clearly shown that it improves event-free survival or progression-free survival when utilized as a maintenance strategy in high-risk AML patients. I agree in FLT3, sorafenib data was compelling, but that group of patients might not have received FLT3 inhibitors during induction. However, recent data from the gilteritinib showed the benefit of maintenance therapy only among those who are MRD positive, and MIDOS tolerance study was negative. So there is a control conflicting data in terms of maintenance therapy in general, and the randomized study in high-risk MDS AML HMA maintenance didn't show to improve outcome. So maintenance therapy is a challenge, and although we all are inclined to give maintenance therapy for this group of patients, but in our study and other studies, we haven't seen significantly improve event-free survival or relapse-free survival. So there is another study from BMT CT and Trial Network where they look at the transplant outcome in high-risk MDS and AML patient subgroup analysis among patients with p 3 mutation. As you can see here, although it's dismal, but there is a modest improvement in survival outcome among patients who receive transplant compared to those who didn't receive transplant. So, in conclusion, future directions, P-mutated AML or myeloneuroplasm are now well recognized as a distinct entity with poor outcome. Several prospective real-world data suggests that transplant is the only factor that can improve outcome in a small subset of patients. We're still in desperate need to novel combination therapies to achieve a better control of disease and remission and improve the outcome of this group of high-risk patients. With this, I conclude and thank you for listening.
Thank you, Dr. Badr. That was a excellent presentation. You comprehensively covered the topic, touching upon the diagnosis, various treatment options, need for transplant, which is the only way patients can have improved outcomes, and good amount of data supporting each of them. So we have collected a few questions from our colleagues. Can we go ahead?
Sure, sure.
So a lot of questions on the diagnosis aspect. So one question from Dr. Srinidhi is, are all TP53 mutations the same? Missense, nonsense, frame shift mutations, are all of them the same or are they prognostically different?
Yeah, so missense is a most prevalent mutation in PC mutation, and their initial data does suggest that missense mutations tends to have a high rate of progression and inferior outcome compared to truncating mutation. And there are different prognostic score based on molecular data as well as the type of mutation that is showed. But I haven't seen or come across in advanced disease, advanced myeloneuroplasm that really plays a role in predicting outcome.
And you very elegantly showed that the TP53 VAF and the frequency, all of them matter in a chronic disease, a low risk MDS, or a chronic phase of MPN. When it comes to advanced disease, be it MPN blast phase or AML, they don't really make a difference.
Yeah,
But in
exactly.
clinical practice, very often we see a heterogeneous response when it comes to standard therapy. So there are patients who respond really well to treatment, go into CR. There are patients who, no matter what we give, they do not respond or relapse very, very quickly. So What are the factors in a AML patient other than the VAF, of course, including the co-occurring mutations, or are there any other factors that predict response to treatment?
Yeah, definitely. I think complex karyotype, complex monosomal karyotype is one factor, and the G mutation that happens after the HMA-based therapy, acquisition of mutations such as RAS mutation, that is also shown in one of our data set and consistently motivated analysis that show to predict outcome. So secondary AML patients who are progressing on HMA-based therapy, MPN patients who develop MP in blast phase, those with complex monosomal karyotype that persist after induction consolidation therapy, these are the subgroup patients which I've seen and which have been shown to have an inferior outcome.
And at your practice in Mayo, when a patient comes in, other than the routine tests, including cytogenetics and NGS, is there any other additional test that you do for these patients for a better prognostic delineation?
No, I think the genomic data and the karyotypic analysis gives you the information what you need in terms of how this patient will do. I think more so apart from the disease-related factor, patient-related factors also plays a role in predicting outcome. And some patients may succumb to either you give intensive induction chemotherapy or ven-based therapy with prolonged cytopenias and may not be able to overcome the insult or the infection they acquire while on the course of therapy, and certain comorbidities exclude them to continue to pursue life-prolonging therapies such as renal dysfunction, liver dysfunction, and so forth. So I think patient-related factors are also relevant when it comes to predicting outcome apart from the disease-related factors. And the resources available. What I see in community practice still in here in US, uh, these patients doesn't get the proper supportive care. Even if they initiate ven-based therapy, it's not given adequately, and there are frequent interruptions and delays, which are not really needed in terms of managing these patients. And time for initiation of therapy and referral to tertiary care center, and even in tertiary care center, from time to achieving remission, let's say with ven-based therapy, whatever, and transplant. Sometimes it takes 3 to 4 months, and these patients aren't receiving continuous therapy to maintain a response, and they tends to relapse after a few months post transplant. So I think there's several factors that comes into play all over in high risk AML or MDS patients, not only with this PIV3 mutation.
So, in a young patient with a TP53 mutation, when would you consider testing for, if you have a biallelic TP53 mutation, for example? Would you consider sending a cheek swab or further testing for looking at mutations in them?
Which swab, like the genetic alteration?
Yes, yes, yes.
Yeah, so in a young individual, definitely we do germline testing, and we have recently opened a study called like interception study, because what we saw that with the increased utilization of CAR T cell therapy, we are seeing secondary malignancies with a very short pace of time, into 3 to 6 months after CAR T cell therapy, these patients are progressing to advanced risk disease with inferior outcome. It may be hold true that these they have a small subclones prior to the CAR T cell therapy, and after CAR T cell therapy, they tends to expand, leading to dismal outcomes. So we open a study and look, we are doing a genomic profiling or testing to determine their germline predisposition for these diseases, and definitely those with ATM deletion, which can co-occur, or CHIK2 mutation, or those with NF1 mutation with high VAF, or those with RED21 mutation. All these are all are put you in high risk for having a pre-existing genomic predisposition syndrome. So I think it's good to have the germline testing.
So when it comes to TP53 in particular, does the VAF of TP53 make you decide whether the patient should have a germline testing, or regardless of the VAF, all young patients, do you do a germline testing?
Yeah, we should do germline testing. all young patients. But if you have a significant high VAF, more than 50% or so in a younger individual, that also should make you think for germline predisposition.
And for a young fit patient with TP53 mutations, let's say with a VAF of 40-50%, what is your choice of induction treatment? Do you treat all of them with low intensity treatments like azaven, or would you give flag with venetoclax? What is your choice in your practice?
Yeah, there was earlier data published a few years ago from MD Anderson where they showed that if you have a VAF of less than 40%, high dose cytarabine can to have a better outcome. Then their flag ida when data set overall in younger individuals they saw high response rate close to 80% and more than 90% of MRD negativity. But if you look at the multivariate analysis, those with PVC mutation tends to have an inferior outcome. So that was the negative prognostic marker. So although in the younger individuals you always inclined to give intensive chemotherapy, but I prefer Ven-based therapy with HMA when it comes to this particular disease, because as I've shown you, data doesn't really support that intensive chemotherapy is an answer for this disease.
So you would prefer HMA when, regardless of the age, fitness, and other
Yeah.
things, in a young, even in a young patient. And again, does it have anything to do with the VAF? Let's say someone with a VAF of 5% versus 30-40%. Would that affect your choice of treatment, or regardless of the VAF, you would go for HMA when?
That's a very interesting question. So we have 5% PUT3 in AML patients. That tells you that that is not the driving factor. There's certain other factors that driving leukogenesis. In those situations, young individuals treating with intensive chemotherapy and taking these parent transplant is a reasonable option. Yeah.
And in these difficult group of patients, at what time point would you consider transplanting them? After they achieve a CR, or would you wait for them to achieve a MRD negativity? What is the ideal time point to take them up for a transplant?
Yeah, so MRD, although there are some centers that claim that they have a very good MRD assay, but MRD, flow-based MRD assay in AML is always controversial, and that doesn't really give you the doesn't give you the good sense that these patients have a better relapse-free survival. But I would say once you achieve remission, you should look for a donor, find a donor, and prepare these patients for transplant as quickly as possible within 3 to 4 months, ideally from the time of induction. Because what you see in our studies and other studies, what they've shown, there's some data on genomic profile from Courtney Denard of MD Anderson published in Blood a few years ago, where they show that with Ven-based therapy, you do achieve a response, but these responses are not long lasting because the evolution of the clone, right, that make resistance. So the median duration of response with Ven-based therapy is in the range of 6 to 7 months. If you want to do something, you need to do during this time point. If you miss that window of remission, that is 6 months from the time you initiate therapy in 30-40% of patients, then when they relapse, it's very hard to salvage them.
And what is the best way of MRD monitoring in these patients? Would you monitor by flow cytometry, or would you do an NGS MRD to look for TP53, or would you do both?
Yeah, I will more look at the karyotypic analysis. If these patients are complex cytogenetics, if these complex cytogenetics have gone away, if they achieve a certain remission, there is a good marker response. Flow MRD doesn't really tell you much, although it correlates with response. Like flow-based MRD, I haven't seen MRD, AML, flow-based MRD that significantly show to impact outcome in individuals who achieve a good response to these. P3 mutation VAF, in our analysis from transplant analysis, there is a small subset of patients, but really that doesn't predict their relapse-free survival post-transplant. But it's a good marker. I think we need to do it more like uniformly to see if that really impact outcome. But I think the karyotypic analysis, if you clear the karyotypic aberrations prior to transplant, and maintain that clearance post transplant, let's say around day 100, that is a better predictor of outcome.
So we recently had a patient, 56-year-old female patient, otherwise fit, ECOG PS1, TP53 mutated AML, VAF of around 56%. We treated the patient with flag venetoclax post one cycle, achieved a CR, but the flow MRD was positive at zero point 0.2. So we decided to go ahead and give one more cycle of treatment with cytarabine. And during the first cycle, also patient had a stormy course, lot of infection, cytopenias, pneumonia. So post remission, patient actually went on to AZA. But before she completed her first cycle of AZA, she relapsed. So in such a scenario, let's say patients achieve a CR after first cycle with an MRD positivity also, do you think if the conditions permit, patient should be taken for an upfront transplant without waiting for an MRD negativity?
Yeah, so you talk about flow-based MRD. It's your
Yes.
validated the flow-based MRD constitution in terms of you have some data that suggests that MRD is predictive or outcome, right? Yeah, in
Yes.
those situations, I will proceed with transplant, and you did the right thing. But it tells you a different biology. Like after two cycle of flag-ida-win and venetoclax, these patient relapse. So it doesn't look that this patient will do good even after transplant because of the resistant nature of the disease. Yeah.
So in these patients, very often achieving a CR should be good enough if
Yes.
they have a match and even
Yeah.
if there is a condition permissive for transplant, it's best to go ahead without giving further treatment.
Yeah. You bet on immune surveillance from the donor rather than chemotherapy achieving the results. Yeah.
And you touched upon maintenance in the post-transplant setting. And many of the centers, including ours, we try to taper off the immunosuppression relatively early, considering that these are very high-risk patients, and we try to put most of them on ASA maintenance. So, what is your practice at Mayo regarding in these patients, let's say considering a matched sibling versus a haplo transplant? When would you consider tapering immunosuppression in post-transplant setting? And do you routinely use azacitidine or venetoclax as maintenance in these patients?
Yeah, we don't routinely use them, but we gauge our maintenance strategy based on the chimerism and based on the surveillance bone marrow biopsy after transplant. If they are if they are losing chimerism, or if we are seeing that the chromosome aberrations are coming back, or the PTC mutation which is not there at day 30 is coming back at day 60 through NGS, then in those situations we do offer maintenance strategy. I think the only maintenance strategy in high-risk MDS AML, although a single-arm phase 2 study, was a low-dose decitabine in combination with GCSF, a GCU paper a few years ago, that has shown to improve the relapse-free survival. And we utilize that low-dose decitabine plus plus GCSF. There's a VLAT trial that has stopped enrolling patients, maintenance HMA when. It's a BMT-CDN study. Let's see what that shows in terms of maintenance strategy with when-based maintenance strategy.
So as of today, actually, there's not much of a solid data to back maintenance even in these patients.
Yeah.
And very often we monitor MRD post-transplant. I'm talking about the NGS MRD and the TP53 mutation itself. So in many patients, 30 days, 60 days post-transplant, we see the TP53 coming up, 0.05% at very, very low VAF. So do you think in that setting, a DLI, other than obviously tapering and stopping the immunosuppression, a DLI or something of that sort would help?
Yeah. So if you are not losing CD3 significantly, chimerism,
Yes.
tapering of immunosuppression and maintenance strategy, HMA and DLI may benefit. But if you're losing CD3, then DLI may not be that beneficial. Uh, if the patient is fit enough for second allo strategy, should we pursue? If the PTC is coming back, more or less the disease will come back. So in those situations, you even if you don't have a great data backing, but you have to do something and try to achieve a disease control for longer time.
because most of the relapses that we have had in TP53 malignancies are very early relapses and typically usually in the first 100 days. And
Yeah.
surprisingly, many of them have been with full chimerism without any fall in T cell chimerism.
Mm, mm.
And does monitoring for MRD intervening or probably adding a DLI, we do not know whether it would be helpful.
Yeah. Yeah.
And we have had patients with TP53 mutated ALL, sorry, who did very well at 1.5 years. You see a TP53 clone coming up, 0.05%. So very difficult situations, very late. We would have expected the immune reconstitution to be complete and other things. But do you think MRD of, let's say, 0.05 or low level MRD is significant in the setting of 1 to 2 years post transplant also, as far as the TP53 mutation is concerned?
Yeah. So in ALL is different. The outcome of TC mutated ALL is way better than AML. And if you in ALL, we have a better MRD technique, which is more validated and more reliable with NGS-based PCR, clonoSEQ. You get a good answer. So this patient had a uh, uh, late MRD positive
Yes,
by NGS, 1 year
yes,
out
yeah, 1.5 years later
in ALL.
in ALL, exactly.
I would say to monitor closely rather intervening, maybe a 3 monthly testing to see. Yeah.
So again, we have a case which has been posted, CA breast, BRCA mutated with TP53 on tissue NGS, treated with PARP inhibitors, now has cytopenia, marrow NGS revealed biallelic TP53. So the question is, do you think the initial TP53 may be an indication for a more close follow-up for therapy-related MDS or AML? So I think the question which is posted is for secondary MDS AML with TP53, let's say post treatment of CA breast and other things, and there is already existing TP53 which is detected on the tissue NGS. How should they be monitored for a secondary MDS or AML?
Yeah, no, the PARP inhibitor, as you know, has been linked to secondary MDS and AML. And more drastically, one thing we are also seeing a PPM1D mutation. Your NGS panel carry that mutation, PPND, and it's also PPM1D mutation. That's also a DNA damage response pathway, and it close
Okay.
follow with the P3 mutation. It occurs in low VAF, and 20-30% of cases is associated with P3 mutation. So I think if you tissue, you saw that. I would say you should utilize strategy to minimize the risk. Like the I'm not very embraced with the oncology after fellowship, and I've been more focused on leukemia MDS. But I think the PARP inhibitor, if you see that you may use them judiciously, a small phase of time, and monitor their cytopenias or blood counts more closely. And if you see that it's not relating, the cytopenia not relating to prior therapy, might need to do a bone marrow biopsy for close surveillance.
So mainly to keep a very close surveillance, and
Yeah,
anytime there is a cytopenia which is unexplained by treatment, probably to look for our transformation. Another question
yeah.
which has come up is elderly male patient evaluated for isolated thrombocytopenia, 60, 70,000 per microliter, non-transfusion dependent. Bone marrow shows no dysplasia, but the NGS throws up a TP53 mutation, VAF of 30%. How would you interpret this? No dysplasia, no increase in blast, only TP53 mutation detected in an elderly male with thrombocytopenia.
Yeah. So in CCUS, the orthocyte undetermined significant P3 mutation, the trajectory of disease progression is not as you see with MDS or AML. These patients with CCUS may remain there for longer period of time before they progress. So as what you do in a CCUS patient, monitor their counts every 3 monthly to 6 monthly and intervene doing a bone marrow biopsy accordingly. But I won't do anything with the P3 seekers per se if they don't have cytopenias or don't have any bone marrow disease.
Okay, so you would basically put them on a close follow-up and look for any worsening of cytopenia or probably observe them without intervening at this point.
And similar data has been seen with other leukemias also. Let's say in CLL, where if you find a 17p deletion, that doesn't merely indicates treatment. You look for certain other factors that determines treatment.
Another question which has come up, I think, again from Dr. Srinidhi is, are there any emerging data on the use of genetic or epigenetic modifiers to enhance the effectiveness of therapies in TP53 mutated AML?
Yeah, so epigenetic therapy, these HMA, have been a go-to regimen to manage this disease. Their initial data suggesting 10 days of decitabine may be able to clear the T3 mutation clearance, but later on, when it was compared to 5-day decitabine, several other groups didn't show a benefit as such. So that data doesn't sustain or validated across the board. So epigenetic therapy has been there always been epigenetic therapy combination when it comes to P3 mutation, and everyone utilizes that. Newer epigenetic therapy, uh, there was some second generation decitabine, godecitabine have been tested, but didn't really show any incremental benefit than what we know with the older decitabine version. So, and then their neurotherapy like CTX, which mainly works on a splicing mutation, have been tested. But to my knowledge, I haven't seen. There was some optimism with MDM2 inhibitor, but that combination didn't really pan out in randomized fashion. So, not much apart from HMA at this point in time.
And on that same note, azacitidine versus decitabine, is there any difference? Like, is decitabine, would you say it's probably a better agent to use than azacitidine in this setting?
Well, you always inclined to use decitabine, right, when it comes to PV3, but I don't
Yes.
know. It's true. It has not been worked in randomized fashion. It's a good question to answer.
And when we are looking for TP53, is there a role of, let's say, if a NGS and other tests are not readily available, it's an immunohistochemistry which can be done on the bone marrow biopsy? Because very often we get patients who are referred to us where the diagnosis would have been made on a bone marrow aspiration biopsy and only a flow cytometry would have been done at best. So if we have a biopsy block, do you think looking for TP53 IHC on the biopsy block would be beneficial looking at it in retrospect?
Yeah, there was one, I think, a letter in leukemia research which I reviewed few years ago that look at the IHC stain, and they swear that it correlates with the molecular data. But of course, the sensitivity and specificity won't be there. But if you don't have anything, at least we can do that.
I can see a question in the chat box. Dr. Rohan Haldar has a question and a very interesting one. Do you check the donor for TP53 germline mutation status if the patient has a high VAF, even if there is no family history of malignancy?
Sorry, can you go again so I can look at it?
Yeah. So if the patient has TP53 at a high VAF, do you
Mhm.
screen the donor also for TP53 considering possibility of a germline mutation?
Yeah, so if a family donor,
Yes, a matched sibling donor. Patient has
yeah,
TP53 at a VAF of, let's say, 60%. So would you also recommend screening the donor before taking up for a matched sibling donor allogeneic transplant?
I think, yeah, it's a good question, and there is across the board in germline Presbyterian syndrome they discourage a family member, but I would first establish a germline uh, molecular alteration in a patient before screening that. So although it's a high VAF, but it doesn't really mean that this patient has germline Presbyterian syndrome. We'll check in that in patient first, and if positive, then definitely we should avoid a family member.
Okay, so what you're basically implying is you would actually do a germline testing in the patient, and if patient has a germline variant of TP53 mutation, then you would screen the donor very
Screen the
closely
donor.
or
If
totally
there are other
avoid it.
options available, I will avoid. Yeah.
Right, right, right. Uh, I think there are no more questions in the chat box, and we have also come to the end of the questions which we have collected. If there are no other questions from anyone, Dr. Talha Badr, that is a wonderful lecture on a very difficult topic and a very, very difficult clinical scenario that we face on a day-to-day basis. No clear recommendations on treatment, no clear recommendations on when to really take up for a transplant and how to monitor post-transplant, including the maintenance and other strategies. I think your lecture and the discussion that followed it threw a lot of light on this difficult topic, and I'm very sure it has provided a lot of clarity in managing these difficult group of patients. So thank you so much for sparing your time on a Friday morning and joining us and enlightening us on this topic. We hope to collaborate with you for further academic sessions in the future.
Sure. Thank you so much, Nikhil. It was pleasure to be part of this webinar, and thank you so much for invitation. And talk to you soon. Take care.
Thank you. And I also thank MQ Pharmaceuticals for providing this platform for conducting this webinar. And I thank one and all for joining in this Friday evening from across the world for this webinar. Thank you all. And we'll catch up with Innovations in Hematology webinar next month with a different clinical challenging scenario. Thank you, one and all.